folks. We are live on YouTube. I will be sending you the link.
Good evening and welcome everyone. It is wonderful to know that so many of you want to learn and learn about the facts and sort the fiction to better understand the environment in which we are working and living right now. My name is Angela Carter, and I am the Executive Director of Roots Community Services, which is a Black-led, Black-focused, Black-serving organization in the region of Peel and Halton regions. I'm also the co-chair of the newly formed Black Health Task Force of Peel, along with Edisiri Uda from Wellford Community Health Services. The task force is a coalition of Black health professionals, community leaders, and advocates committed to advancing Black health within the region, to build a stronger, healthier, and more equitable healthcare system responsive to the needs of Black communities. Today, we have a panel of trusted health professionals to provide you with up-to-date and factual information in a manner that you can understand and in a safe space. They are not here to tell you that you should or shouldn't take the vaccine. They're here to provide you with evidence-based information so you can decide what is best for you and your family. We encourage you to post your questions in the question and answer box, and we will answer as many as we can today. The ones we cannot answer, we will collate and seek answers that can be shared in another forum. Please note that this session is also being recorded so that we can share it with others and can post it for you to review and for others to listen to. Before we do get to the panel discussions and to hear all of the questions and what the professionals have to say, I will ask Monique to present the land acknowledgement. Monique?
Thank you, Angela. We will begin the Black Health Task Force of Peel's Town Hall meeting by acknowledging the land we are meeting on in its traditional territory of many Indigenous peoples, including Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis people. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. We recognize and deeply appreciate their historic connection to this place and the contributions they have made, both in shaping and strengthening this community in particular, in our province and country as a whole. As settlers, this recognition of the contributions and historic importance of Indigenous peoples must also be clearly and overtly connected to our collective commitment to make the promise and the challenge of truth and reconciliation real in our communities, and in particular, to bring justice for murdered and missing Indigenous women and girls across our country. The acknowledgement of the United Nations International Decade for People of African Descent, 2015 to 2024. We also acknowledge the United Nations declarations of the International Decade for People of African Descent, 2014 to 2024, whose objectives are promote respect, protection, and fulfillment of all human rights and fundamental freedoms by people of African descent. Promote a greater knowledge of the respect for the diverse heritage, culture, and contributions of people of African descent to the development of societies. Adopt and strengthen national, regional, and international legal frameworks. We are 3 years from the end of the decade, and as a community and a region, we must continue to work collectively to achieve the objectives of the declaration. We are therefore calling on everyone, individuals, organizations, elected officials, government, to learn more about the reason for the declaration and to make a commitment to address at least one of these objectives. Thank you.
Thank you very much. Monique, for that. Thank you. And just before we get and I introduce you to the moderator who's going to take you through, we want to gauge how you're feeling about the COVID-19 vaccine anyway. And we post a poll online for you to just answer one question, right? Unfortunately, this can only be done with those who are on video. So how confident are you in taking the COVID-19 vaccine now? Could you answer? I just give you a couple of seconds, minutes to answer. So how confident are you in taking the COVID-19 vaccine now? For those who are on video, we really would love to hear your answers. And in the meanwhile, it's my pleasure to introduce to you Dr. Dion Duncan, who is going to be our moderator for today's event. Dr. Duncan wears many hats, too many to showcase here today. And after more than 18 years working in the life sciences sector for a large multicultural conglomerate, Dr. Duncan decided to expand her career in the area of research and innovation and focus on the nonprofit sector as a clinical director of operations. She currently heads the Teresa Group, a public health accredited facility within Ontario that specializes in the care of infants, children, youth, and families living with HIV/AIDS, as well as she holds the position of Vice President of Development for the Rosas Center in the Halton region, a facility that supports those living with physical disabilities and acquired brain injuries. While working with the Division of Brain Injuries, Mental Health and Infectious Disease, Dr. Duncan became aware that there was a high propensity of ethnic and racialized individuals who suffered from infectious disease coupled with mental health concerns, all while having to navigate a very complex healthcare system in Canada. She committed a large part of her career to understanding the reasoning behind the epidemiology of this increased mental health and immune deficiency in racialized communities, and how she can support this sector of community members. Dr. Duncan holds a PhD in informatics and policy from the University of Toronto, an executive MBA from Kellogg Schulich School of Business, a bachelor's in science and political management from York University, and a Bachelor of Arts in sociology and communication from York University. And if that was not enough, she decided she was going to get into politics at the provincial level and threw her hat into the ring in the riding that was held by the late, the Honorable Lincoln Alexander. And she did this back in January 2018. And that is in the riding of Hamilton Center. I now present to you, Dr. Duncan.
Thank you very much for that lovely introduction. It's a pleasure to be here this evening. We have amassed a panel of amazing physicians and researchers, and I am proud to let you know that tonight will be a night of information, a night of education, and a night of understanding. It is my pleasure to now introduce our Medical Officer of Health, Dr. Lowe. On June the 25th, 2020, Dr. Lowe became the Medical Officer of Health at the Region of Peel in Public Health. He was previously an Associate Medical Officer of Health and served as the Interim Medical Officer of Health in Peel. Dr. Lowe is an adjunct professor at the Dalla Lana School of Public Health, University of Toronto. He completed his undergraduate training and medical school at the University of Western Ontario and his residency at the University of Toronto, during which he also earned a master's in public health at Johns Hopkins. He is board certified in family medicine in Canada and in public health and preventative medicine in both Canada and the United States. As the Region of Peel Medical Officer of Health, Dr. Lowe reports to the Regional Council on all public matters that are of concern or deemed hazardous. He provides direction to public health staff and acts as a main spokesperson on public health issues and strategies. Under the provincial mandate, public health programs, and use of population health approaches, we focus on the upstream efforts to prevent diseases and to improve health. This is one of the main areas that he focuses on, while addressing the differences in health outcomes among and between groups. With all of that, obviously, he still has time to spend with his family. Dr. Lowe enjoys running, music, and spending time with his wife, Jamie, and his two daughters, Jessica and Leah. It is a pleasure to welcome you, Dr. Lowe, this evening. Thank you.
Thank you so much, Dr. Duncan, for that very warm and very elaborate welcome. I think it really overstates to some extent what is an honor and a privilege for me to be here with all of you, the Black Task Force, this august panel, and certainly the leadership of Angela and Ed Siri in really trying to talk about a very important matter that is facing our community, not only the COVID-19 pandemic, but also the broader question around vaccination and how it is so critical that all of us together really work to understand the importance of the ongoing vaccination rollout, and how we can make sure the questions that you have both around the actual process as well as the vaccine itself are answered. And I do know that many of the other members on the panel here are very esteemed physicians. Dr. Abdurrahman, certainly I've worked with you in the past, and just to fully share, I one of my daughters was taken care of by Zainab, and I trust her with my family, and certainly so we're really great to see you and really great to see everyone on the call this evening. It is a tremendous honor to be here. Advancing health equity is one of the strategic priorities for the region of Peel, and it was such even before the pandemic response. And I do want to say that while unfortunately I have a conflicting event with Madam Mayor Crombie of the city of Mississauga this evening, so please don't take an early departure as a sign of disinterest in the community. It is simply just that I am unfortunately in too many places at the same time, but I was honored and did want to make the time to speak with all of you. Public health here in Peel has recognized that in the course of our battle against COVID-19, we are only one part of the community response. Certainly we're involved in the case and contact management, the contact tracing, putting out advice around recommendations, surveillance, certainly acting as the spokespeople and communications around the progress of the pandemic, as well as the progress of our efforts to control it in our community. But throughout the pandemic, we have been grateful for the opportunity to work alongside community partners to ensure that the response considers things like equity, engagement. Certainly members of this panel and the Black Health Task Force of Peel have really been great partners in working on collaborative initiatives, among them including the Region of Peel's Community Response Table, the Peel High Priority Community Strategy, and also the Peel Mass Vaccination Plan through the Community Engagement and Advisory Table. So there are a number of connections, and I would always welcome the opportunity for more. All of these forums are helpful for us in the course of our work as public health professionals to address what we all know and have seen as a disproportionate impact that COVID-19 has had on many communities of color, many racialized communities within our community. In fact, Peel Public Health was one of the first health units in recognition of the diversity of our community to begin collecting socio-demographic data. It was actually that data that highlighted that our communities of color are overrepresented amongst our COVID-19 cases. 86% of our cases were individuals who self-identified as a person of color, when we know that proportionally they only represent about 63% of our population. So, I think the data has been one crucial and fundamental aspect of our ongoing response, and also our ongoing conversations with all of you as partners in the community. But we also know that we must act on the data. And to end the COVID-19 pandemic, or at least bring community transmission to more manageable levels, we need to continue following the public health measures and also vaccination. The measures we've all heard numerous times in terms of distancing, masking, testing, and self-isolation, especially with variants in our midst. It's crucial to keep that up. It's also one of the reasons why Peel Public Health has taken such a strong line on topics such as worker safety and paid sick leave, with a recognition that particularly many of our communities of color are employed in jobs, in positions where precarious employment or the nature of the work render them differentially vulnerable compared to the rest of the community. And so I think that's the first and foremost foundation, is trying to continue to get supports to people who can't work from home, as well as ensuring that those of us who can are staying home as much as possible, are continuing to stay physically apart, but emotionally connected, virtually connected, while making sure that anything outside the home really continues to follow those precautions. But vaccination, which is the main topic of our panel this evening, is so crucial. And I think it's we're trying to reach out in various ways. This forum is an example, and through our various collaborations to try to communicate further information, to address and answer questions you may have about vaccination, engage to understand barriers, understand how we might be able to get individuals to vaccines, to clinics, to increase confidence. These are all important things that we will do with all of you as a community, because I think the most important thing is to really highlight, we have some early evidence, even here in Canada, of the effectiveness of vaccination. In the rollout in long-term care homes, we know that long-term care homes had higher rates of, certainly mortality and severe outcomes. And certainly our thoughts are with all the families and the individuals who are impacted. But we, through the provincial rollout, prioritized staff and residents of long-term care homes. And we now have seen, just in the last few weeks, that there has been a reduction of 80 to 90% of COVID cases in our long-term care homes amongst the residents and healthcare workers that have been vaccinated, compared to those that haven't been vaccinated, based on a provincial study. So we know that vaccines work. We know that vaccines are our way out of this. And to the extent that the vaccines that have been developed are safe, are effective, as determined by our federal counterparts, we want to make sure that we can provide that same confidence to all of you, and be able, and certainly all of the panelists who will be able to really share their expertise to answer your questions and ensure that you get the information you need. And I want to say, in saying all that I recognize that ultimately COVID-19 and our society as a whole still has a lot to do around historic and systemic discrimination, and really to work on anti-racism. And I fully recognize that a lot of the hesitancy that exists or that may exist in certain communities of color really relate to an understanding that the system has traditionally not been an institution that can be viewed with the lens of trust. But certainly the Region of Peel recognizes this, and in June last year, our council passed an anti-Black racism motion, and our regional corporation, including the Public Health Unit, continues to work internally to address concerns that are arising and assess our overall workforce diversity, trying to address systemic discrimination through an anti-racist lens in our own work. So I do want to close by saying, again, thank you for the opportunity to speak. If it were another night that I didn't have to, spend some time with Mississauga's mayor, I would very much have enjoyed staying to hear the entire conversation. But I want to make very clear as well, you can reach out to me anytime. You can reach out to our public health unit at any time. I often say, if you've got a public health concern, come chat with me. If I'm the public health concern, then you'll have to chat to the Board of Health. But long story short, it is an honor and privilege to be here and to take some time to address all of you. And I want you to know that we in Peel Public Health, especially moving into this, the most difficult phase of our pandemic, look forward to working with the Black Health Task Force and the Black community side by side as we aim to bring this to a close in our community. Thank you for the privilege of speaking to you tonight.
Thank you so much, Dr. Lowe, for that wonderful review and for making us feel comfortable and feel safe as well as letting us know that we have a forum where we can inform each other about what is transpiring, about our feelings of uncomfort, and subsequently about any additional questions we may have at a provincial level or at a clinical level. What I'd like to do now is continue to talk to you about this great panel that we've amassed. I'd like to now introduce Dr. Akwatu Kenti. Dr. Akwatu Kenti is the Special Advisor to the City of Toronto's Equity Initiative and Chair of Black Scientists Task Force, as well as Vaccine Equity. Dr. Akwatu is an affiliate scientist with the Institute for Mental Health Policy Research, also known as the IMHPR, at the Center of Addiction and Mental Health, CAMH, and an assistant professor with the Dalai Lama School of Public Health. He's formerly the Assistant Deputy Minister of Ontario's Anti-Racism Directorate between 2017 and 2020, as well as CAMH's Director for Transformative Global Health. This was between 1997 and 2017, long-standing career. Dr. Akwatu has a specialist degree in economics, a master's in political science from the University of Toronto, and a PhD in health policy and equity from York University. Dr. Kenti has inspired many local efforts to improve Black mental health across Latin American and Caribbean communities through intensive regional substance abuse training program, as well as addictive disorders. He also developed an anti-stigma intervention in primary healthcare in Ontario and has co-led drug research capacity building for the past decade. He's also involved in the Inter-American Drug Control Commission, or the CICADOAS, involving 30 universities across Latin America and the Caribbean. Dr. Akwatu was a researcher on development, the easy to follow, culturally adaptive, cognitive behavioral therapy known as CBD, interventions for working with individuals in Latin American origin, as well as Afro-Caribbean origin in both English and French. This CBD intervention has been applied even with voodoo spiritual leaders in Haiti to access whether they can strengthen a system of informal care. Dr. Akwatu also led the development of specialized drug treatment and prevention programs for Black youth in Toronto, entitled the Substance Abuse Programs for African and Canadian Youth, the SAPACCY. His doctoral research chronicled the efforts of social determinants of racialized gun violence in Toronto in 140 neighborhoods between 2004 and 2014. Welcome, Doctor.
Pleasure to be here.
Glad to have you, glad to have you. On the panel with you from a neighboring perspective, we also have Dr. Zainab Abderrahman. Now, I am incredibly pleased to also welcome you, Doctor. As an adjunct assistant clinical professor at the Department of Pediatrics at McMaster University, she is a graduate of the University of Toronto Medical School, and she completed both her pediatrics training as well as her subspecialty training in clinical immunology and allergy at McMaster University. At McMaster Children's Hospital, she's an allergy lead as well as a special immunization clinic focusing vaccine allergy specialist. She also practices as an allergist and clinical immunologist in communities across Toronto, as well as Mississauga. At the provincial level, she is a section chair for the section of allergy and clinical immunology at the Ontario Medical Association, as well as a member of the OMA Civility, Diversity, and Inclusion Committee. She is also a fellow in training, co-supervisor for the Canadian Society of Allergy and Clinical Immunology. Welcome, Dr. Zainab, welcome.
Thank you so much. And I'm also should say I'm very proud to also be on the Black Scientist Task Force, which is led by Kenti as well. Thank you so much for having me.
We are so lucky to have you. This is wonderful. On the panel today, we also have Lydia Joy Marshall. Lydia Joy Marshall has a long history of championing health equity for those who've been marginalized by race, especially in our diverse Black communities. With a bachelor's in biology and a master's in human genetics, she focuses on ways in which to improve the overall health and wellness from a basic scientific lens. Currently, Lydia Joy sits as president of the Black Health Alliance and continues to work as an advocate in healthcare reform, as a community lead with Health Commons Solutions Lab and a research associate with the Kidney Health Education Research Group, University Health Network. Welcome and thank you for being here. Joining us also this evening, we have Dr. Sandra Romain. Welcome, doctor. She obtained her Bachelor of Science in Anatomy and Cell Biology at McGill University in Montreal. She then went on to obtain a Master's of Applied Science at the University of Toronto in Peel, Black Health Task Force Department of Mechanical Engineering. She obtained her medical degree from the University of Ottawa and then completed her residency in family medicine at the University of Toronto, and has been part of the Well-Fort family since 2018 as their primary care physician. She has been working collaboratively with the Diabetes Education Program, the Bloom team, and is actively also involved in mentorship of medical students, medical residents, and nurse practitioners. Dr. Romain also has active privileges with the William Osler Health System, providing inpatient care to residents in Brampton and surrounding areas since 2009. She's an attending physician for long-term care residents in Peel. And most recently, she's an important figure in Peel's vaccination effort by working at the Osler Vaccination Clinic. Thank you so much and welcome.
Thank you. Thank you for having me tonight.
Glad to have you all here. I cannot tell you what an esteemed group we have. We will be entering into a series of questions that have been brought to us by our community. We received a myriad of questions. I cannot tell you. We may need more than one town hall this year. But with that being said, let's allow and let's use this opportunity to answer as many questions as we can for the curious, for the interested, and for those who really need some direction. With that, I will lead to you, Angela.
Okay, well, one question that's come in that is really, I guess, key, people just want to know, what exactly is in the vaccines and what research has been done to ensure efficacy and safety?
So from a direction perspective this evening, what's going to transpire as moderator is I'm going to pose questions to the physicians on panel tonight. And I will also open and allow other physicians to add material and or understanding. I would like to open with Dr. Kenty pertaining to that question. Dr. Kenty, if you could please answer.
I was actually going to say that's a perfect question for Zainab. I would only say that no corners were cut in the development of any of the vaccines, and that Blacks were approximately 10% of the clinical samples for all the vaccines. In some cases more, in some cases just a little bit less, but all the vaccines are methodologically sound, have gone through intense scrutiny, so we can have confidence in these vaccines. I mean, and they've been rolled out across the world with minimal harms to the populations that's been served. I think Dr. Zainab could actually get into what's actually in the vaccine, because there's different types of vaccines that require that particular level of expertise that only she has. Over to you.
Thank you,
That's
Dr.
okay, doctor.
Kenty.
Thank you.
So yes, currently in Canada, we have 4 vaccines that we are currently going to be using. So there's 2 categories of them. The first would be the Pfizer and the Moderna vaccines, which were the first ones to be approved. And those are called the mRNA vaccines. And so in terms of what's in them, They both contain a small piece of mRNA, which is essentially it's a blueprint. It basically goes, once you get the vaccine, it tells your cells, please make this type of protein, and you make a tiny portion of the protein that is the virus. You're not able to make the whole thing. It only tells you how to make what's called the spike protein, which is a tiny part of it, but a part that's part of what makes these viruses called the coronavirus. It gives it the crown. So that's what corona means. So it takes that, and then your body makes that, and then your body learns to make antibodies to it so that you can recognize it if you get infected. So that's the main ingredient. The other ingredients are things to kind of help keep it so that it stays to be delivered to your immune system so that it doesn't get degraded. So it's in what's called a lipid layer, or really an oil and water kind of envelope, so that it can stay suspended so it gets delivered in the vaccine. So there's different kinds of fats in there. Nothing from animals, there's synthetic cholesterol and such. And then there's also what's called polyethylene glycol, which is in things such as laxatives and other medications we use all the time. And that just helps stabilize it as well. And then there's some salts. So just that helps kind of maintain the pH. So those are the mRNA vaccines. In terms of the other vaccines, they're called viral vector vaccines. So essentially, you're still going to get a little bit of coating of that protein to kind of see the protein. But what they do is they instead give it on a vector that looks a little bit like an adenovirus, which is something that we see in terms of colds and stomach bugs. They're using a non-human one, and then you're getting that presented to you, and then your body makes antibodies to that. So it's just another way of presenting that same spike protein to your body, just using a different type of technology. And this is something that many people are probably used to in terms of other types of vaccines. And once again, they also contain salts and buffers in there as well. And this one also has polysorbate, which is similar to the polyethylene glycol, which is another thing to help in terms of buffering and keeping things stable for the delivery to your body. And as much as I know everyone's focused as what's in the vaccine, I also want to point out what's not in the vaccine. There's no foods in it. So if you have any food allergies, you don't have to worry. There's no antibiotics. So some of our previous vaccines would have that to kind of prevent infection, but there's no antibiotics in these. So if you have, penicillin allergy or sulfa medication allergy, you don't have to worry. There's also no dyes in it. There's no environmental allergens like, grass or tree. There's no venom. So like bee sting or anything like that. There's none of those inside this vaccine. So it's very important what's not in it as well.
Thank you very much, Doctor. Thank you. And question? Angela, may I have the next question?
Sorry about that. It was on mute. Oh my goodness. I'll follow up on that. Someone has written here, I heard on the news today that there's evidence that AstraZeneca could cause blood clots, and as a result, they have stopped using it in some parts of Europe. However, Canada will continue to use this vaccine for age group 60 to 64. What do you think about this?
Dr. Zainab, I know that you just answered, but if Dr. Lowe and you are both on, if you could both appropriately respond to this in terms of the AstraZeneca vaccine, I would appreciate that.
Absolutely. So in terms of that, there were few cases of those who had blood clots. So a few countries have said they want to further investigate this. As it stands, there hasn't been a specific correlation that's found that the development of the blood clots have been directly related to the vaccines. So that is currently being investigated. And as I understand, they're really looking at a specific batch, I understand, so they've kind of paused. But as far as I understand, in terms of the frequency of the blood clots, it's actually it's not above the regular frequency of people developing blood clots in the general population, because there's a certain portion of people who develop blood clots regardless. And in the studies, there wasn't an increased risk for clotting that was seen in the studies, which actually still had thousands and thousands of people. And there are other countries that are continuing. It's only been actually, I believe, 1 or 2 countries they've temporarily suspended it, but it's actually been in use in other countries for longer, and they continue to use them. They haven't had this issue. This is not unusual to hear about some signals here, some signals there, and trying to figure it out, because this is the first time a vaccine's been rolled out where we're so actively involved in following any single thing happening. So, when we first started with the Pfizer and the Moderna one, there were some cases of anaphylaxis. Everyone was watching it very carefully. We thought we were going to see high rates of anaphylaxis. With any vaccine, we see 1 per million doses will give us anaphylaxis. And now we're seeing, yes, it's about 2 to 5 per million doses with Pfizer and Moderna. So this isn't unusual that you might hear about these happenings and then we further investigate them. This happens with every vaccine you get. So anytime you get a vaccine, if anything happens to you in the days to weeks afterwards, it gets reported and it gets fully investigated to see if it is in any way related. So we're just hearing about these reports even before they're getting fully investigated. Typically, you hear about this a year later about this was looked through and none of these happened with these routine vaccines. But this is part of the vigilance. So anytime we're concerned about anything, we fully investigate that. So that is being done. So I hope that also reassures you that they'll be fully looked at, but at this point, they have not seen a specific correlation to say it's increased with the vaccine compared to the regular population.
Okay, and I know that earlier on, there was also a question pertaining to taking the vaccine and getting lumps and nodes over the body. If you could just add on to a tail end of that, or if you could answer that question quickly, you would cover a lot of questions that people had about lumps and bumps.
Okay, so sometimes they get a little overexcited about the immunology, but what happens when you get any kind of a vaccine is it activates your immune system. We're tricking your immune system into thinking you're fighting this infection, right? And the way it happens is then they take up little bunches of these little pieces of what they see and they take it to your T cells and your B cells and they trigger and they start to try to make more of the antibodies to it. And the way they do that is they go actually into your lymph nodes, which are those small, you feel them sometimes in your neck. If you have like a throat infection, you can get them in your armpit if you get, a shot in the arm. So that's normal. So for a lot of us, you get a little bit of enlargement, but you may not notice it. But 1 in 100 people might notice it more where they can feel their lymph nodes. You get it in the arm, so it's very typical to get it sometimes in the lymph nodes in your arm or in your armpit because that's a normal place to drain. Some people will even get it into their neck and such, but that's just part of your immune system getting activated. That's where a lot of our immune system is making basically the artillery we need for later when we go to battle if you do get infected. So these are just common things that can happen, and they happen actually with any of the vaccines, or if you actually get infected with a common cold. These are all things that can happen. So it's just your immune system getting to work. So you can just kind of say that you can see your immune system working.
Oh, you love the immunology area. I can tell you are loving everything immune based. Did anybody else want to weigh in on that question before I lead back to Angela?
No, she did a fantastic job as per usual.
Right?
Yeah, I'm just excited listening to her. I think I'm just...
Okay, so then Angela, what I will do is I will lead back to you to another question. Thank you.
I'm going to ask, so many questions are coming in here about the vaccine and the efficacy of it. And one person wants to know if they can share the efficacy rates of the different types of vaccine and possibly to speak to the effectiveness of the prevention of hospitalization and death, and which vaccines have higher efficacy rates among certain populations. For example, seniors versus other demographics. And leading on to that is, why is AstraZeneca not recommended for people like my mother? This is one person is saying over 80 years old. So, I think a lot of people are concerned about, and a lot of questions are coming in like that, what is in the vaccine, the efficacy of it, why is it only good for one age group and not the other? So if you could, all of you answer those questions, in general, to say that, because a lot of questions are coming in that way.
Yeah, so there's a natural component or sort of biological component which Zainab can speak to very well. And the only point I would make is all the vaccines can be used. And whatever vaccine comes to you, take the vaccine, because that vaccine will either save your life or reduce the severity of the illness to which you were exposed. It doesn't matter if the vaccine efficacy is 70%, as is the AstraZeneca, or 95% as is the Pfizer. Both vaccines will reduce the symptoms you experience and save, and very likely save you from a mortality risk due to COVID.
Well said, Dr. Kenty.
No, the specifics, just in terms of how the vaccines work, there are two different types. I'll let Zainab elaborate.
Immunologist.
Okay, so I mean, I've talked about how they work. I think, people get a bit caught up in some of the numbers. So I know when you first hear it, you might think, oh, the Moderna and the Pfizer reported 94 and 95%, and now AstraZeneca and Johnson & Johnson, you're talking about 60 to 70%. That's overall it reducing all forms of COVID infection, okay? And so that's important. That includes very mild infections for people who may not have had a lot of issues. But you know what they all do is they all have 90 to 100% reduction of death from COVID-19, as well as severe infections, which will lead you to be in the hospital. And once you get hospitalized, your risk of death just skyrockets up. So all of them are as good at that part. And that's the part we're really focused on. So because we know that if you get admitted, if you're having severe infection or obviously dying, those are key things. But then the other overall numbers you're hearing kind of with the 90 versus 60 to 70% is for all infections. So that's mild for people who, you'll swab them, they have it, they maybe have just like a little bit of the sniffles, but they didn't just develop much else. So yes, for the other ones, you might see it, you'll get even less of that compared to the other ones. But in terms of the ones the key factors we follow, which are death and severe illness, they are all like in that 90 to 100% reduction of that. So you're still gonna get good protection regardless of what you get. The question about AstraZeneca, why it's not, in Canada, it's not being given in those 65 and above. And that's because the National Advisory Committee on Immunization, they make the decisions in terms of who should get what. And they felt that in those studies, they didn't have enough people over 65. So they said, you know what? They had most of the people were 18 to 65 in the study. So let's focus on that population for this vaccine, because they just didn't feel there was enough people. When we're talking about, lots of thousands of people, they're looking also at the age. So they want to know that they can, recommend something that is very robust for that age group. So that's why they have opted not to. Who knows, over time, as we're getting real world data where it's being used and they have more numbers, that might change. I think the one thing we've seen in COVID is that we're constantly changing where we stand on things based on real world knowledge. So that might change in a month or two, who knows? But at this point, they've said, let's wait to see, because we don't have enough data. So we'll work with the two vaccines that are available that had a lot of population that were over 65. Like they went up into the 80s in the mRNA vaccine. So that's why the focus is using that for them at this time. You want to know anything you're using was properly studied in each of the populations. And this is why also you're not seeing it in children yet. Those studies are actually currently being done. Mm-hmm. And that's why we can reassure you, people are worried these weren't fully studied. This is because of how they're studied that we make these recommendations. So we won't kind of change things without evidence.
Well said, Dr. Nayed. Dr. Zayed. I'd also like Lydia Joy as well as Dr. Sandra Romaine to chime in. I'll tag on to the latter part of what you said as well. When we're looking at test cases or when we're looking at guidelines and how they are put together, the analytics are based on test groups. There was a short period of time for this vaccine to come together. So they didn't take a subset of people 65 to 80. It was other subsets that were pulled together and where the testing took place, where they could kind of analyze the variances and see what was transpiring. So that was answered incredibly well. I hope it was helpful to the audience and to the community. Lydia Joy, I'd like you to weigh in on what you're hearing from a community perspective in terms of fears or in terms of people who are very interested in getting to the front of the line, followed by Dr. Romaine.
And I actually would also just like to add to that from my research background. I just find it I'm very happy the questions that are coming up, because we should be questioning, right? Sitting both in my community seat and research seat, it is important, given our history in research, given our history in the community, that we ask these type of questions. And I think they're very valid. I think, the idea that there's so much more scrutiny on this. Like, this is the type of work that us as researchers do all the time. These vaccines, this process, it seems so new, and so many questions in the general public, because that's not part of the everyday conversation. But every medication, every vaccine, similar conversations have happened. And one thing that even for myself, I found very interesting, the same model that even AstraZeneca is using in this mRNA model, this was actually done also for Ebola. It was the same process was done, even a shorter period of time, and it was done with our people, for our people. So, you know, it's just to point out that I know it just seems incredibly strange, the rapid period of time and the mechanism, but this mechanism has been done before, just was not in this viral type. And so in terms of the conversations in community, you know, that's what I was speaking to. It is very a valid conversation that we have questions. I don't like the hesitancy conversation necessarily. It's not an invalid hesitancy. It's a valid reason that things have happened. Why, you know, if you continuously have a door slammed in your face, or you get hit by the same ball in your head, you're going to duck, right? You're not gonna, that's not a just being hesitant, that's a valid step aside. So, you know, that's not to say that we should not be participating, but we have to have conversations like this, that we understand how were we accounted with within this conversation. I saw one question pop up that asked, you know, how many Black people were part of these studies. So there's been about 10% of the studies were done actually in Black population. Now that in itself means something else, because, you know, we have so many diverse groups. We have so much heterogeneity, meaning there's not one set of genes that we're testing it in, but we are testing for different social economics, so for different areas. So it's, in this case, we have been included within the research. However, you know, the conversation in community is that, you know, well, why is now the attention so much in our community? We're even having this panel right now because all the groups are saying, well, Black people are disproportionately being impacted. And I understand why it feels very targeted and not necessarily in a positive way. You know, we've had many health disparities before this, and there wasn't such attention in ensuring that we were included in the conversation. So it lends to why we have these questions, but it's why we have to now take this opportunity that, yes, while this crisis is happening for the greater community, that we ensure that we are setting up conversations and places that in the future, we are always part of the conversation. And I think, you know, going forward, we don't want to wait until a crisis happens and we're seeing that we're being disproportionately impacted to say, hey, how were we included in this? We have to ensure that going forward, that's part of the conversation all the way through, that we are fighting for equity. We are fighting to ensure that these questions and a lens of ensuring that everyone's been included in testing, in conversations, in rollout, that we are part of those conversations from the beginning. And I think that's what this situation has taught us more than anything else, that this is a model of what we were not doing well before, that we have an opportunity to now do differently going forward.
Well said, Lydia Joy. And I will just tag on to that and say that we have a large majority of individuals within our community at a clinical perspective and a clinical level, RPNs, RNs, PSWs, nurses, and physicians, and researchers. And we are in close contact, not only with the patient, but with the vaccine or with the community member. So everything that Lydia Joy just said is really key, making sure that we have equity when it comes to collaborative conversation, and that we are brought to the table and that we are heard. I'd also like to ensure that we ask any of the other doctors, particularly Dr. Romain, if you have any comments on this particular issue.
Yeah, thank you. I just wanted to add as well, as Dr. Zainab said so eloquently earlier, that, you know, the vaccine actually helps your immune system to actually make this protein, right? Like this protein that will then develop into antibodies and then, you know, protect you if you were infected with COVID-19. But at the same time, we have to remember a vaccine is not a substitute for all, you know, the excellent public health measures that have to continue, right? This is very, very important. It is one tool, but we still have to continue to, you know, maintain social distancing, washing your hands, isolate, and obviously test. The more we test, the more we're putting ourselves, our colleagues, our family, you know, in a better situation. So that's one thing I wanted to mention. As well as when it comes to, again, using your immune system. I think where the discrepancy lies in some of the vaccines, especially in the elderly population, you have to remember that you're working with what you have. We know that immunity declines, you know, as you age. And again, that's where, you know, diabetes control is very, very important, because we do know, again, diabetes is a significant risk factor, not only for COVID-19, but for ongoing infections, for obviously other conditions such as heart disease, but we won't, obviously that's not the focus of this discussion tonight. But again, I really want people to appreciate that and understand that at the end of the day, you know, we're not here to tell you what to do. We're not here to dictate what is best for you. We're giving you tools, evidence-based information to make sure that you are able to, you know, make, you know, informed decisions about your health, your family. And again, being in a public health crisis, obviously your colleagues and the people around you.
Can I add to that?
Please.
Yeah, I just wanted to say that the big difference is also race-based data. 1 year ago, March 2020, the idea circulating was that Black people were immune to COVID. We couldn't get COVID. And then Idris Elba, the actor, got COVID, and all of a sudden things stopped. But having race-based data is what has allowed us to see that not only are the positivity rates 2 to 3 times higher in Black people who, you know, are in certain occupations, live in certain neighborhoods and make certain amount of money, but the hospitalization rates 2 to 3 times in Black people as they are in white people. And yesterday, StatsCan revealed that across this country, Black people die at twice the rate from COVID as their white peers. Without race-based data, we would still be saying Black people don't get COVID. I mean, you don't have to worry about COVID. And there are people who are saying you don't have to worry about COVID, but those mortality rates, those hospitalization rates, and that positivity rates indicate very clearly that we have to be worried about COVID.
Dr. Kenty, well said. And I want to also echo the comments of Dr. Romaine. Getting a vaccine, not getting a vaccine, or getting a vaccine is not the answer to everything. It's making sure that you wash your hands and you follow through on all of the protocol. Dr. Kenty, your last comments pertaining to race-based informatics and information and analytics is what is key to solving many conditions that we ail from in our community. Angela, I'll leave to you with the next question.
Okay, your answers generated more questions along that line too. So I'll have one that is kind of different. Why is government and pharmaceutical companies deciding not to be liable for any problems that occur out from the vaccine? Probably if they were, they say this maybe would reduce the would increase a trust factor with the government. So why is that? Why is the government and pharmaceutical not will not be liable for anything or any damages out of the vaccine?
This is more of a socio-political question. It's open to all doctors on the panel. It's open to all specialists as well. Who would like to weigh in?
Well, I think that might be a question best directed to a political figure or someone who would, a different level. I just say that when it comes to risk, the risk of the vaccine are fairly minimal compared to the risk of COVID. Out of 1 million people, 11 out of 1 million have had severe allergic reactions, potential death risk. Whereas when it comes to COVID, we know that it's 2,000 per 100,000 in America. And since we have a similar kind of pattern, we may actually have the same high level of risk. So the two, you put them on a scale and it just goes like that, because the risk from the vaccine is nothing compared to the risk from COVID. And you don't need the government to be involved or to tell you that. You just need to look at the risk.
I agree, Dr. Kenty. Examine the risk and do what is needed to maintain health and follow the compliance orders based on social distancing. Does any other individual on the panel want to weigh in on this particular question, or shall we lead to the next one?
Okay, I'll go to the next one. So based on what was said earlier, if the rates in Black people are so high, why was only 10% included in the studies? Shouldn't majority be included in that case to ensure efficacy and safety?
Well, I think, I mean, again, these are voluntary studies. So I think there has to be a will from individuals to want to partake in this. And again, you have to remember that these studies they were recruiting for these studies, a year ago, right? Obviously, nobody knew that we would be here today with such, significant health crisis. So whether there's specific research based, on race alone, that, I'm not aware of. Maybe some other panelists will be better suited to answer that. But again, we have to remember that the data that we have thus far has been based on, voluntary subjects. And I also just want to maybe backtrack to thinking of SARS. When SARS hit, we have to remember that these two viruses are very, very similar. And we did have a lot of data from SARS as well when it comes to mRNA vaccine. Same with MERS, right? With type of virus. And so there is data, but again, maybe obviously more work I think needs to be done when it comes to research, maybe about a little bit more racialized type of research for the coronavirus, yes, and the vaccine as well.
Well answered, Dr. Romaine. I will add on to that and specify that it truly has to do with the CARV. When they are looking at testing, when they are calling people in to do clinical trials, the CARV is not something that happens exactly when you're in the middle of the virus. It could be something that's happening years before. But it's where are they getting their CARV from a community perspective? Are they going to the outskirts of Nunavut? Are they going to deeper Halifax? Are they going where our people actually reside and live? And are they making our community aware of the fact that they would be testing or doing a clinical trial or require individuals to come in at a volunteer base to do testing? There's also a level of reluctancy historically within our community, whether we're looking at the US or Canada on testing scientifically. And, you can read several stories and several books about whether, it's what happened in Tuskegee or if it's what happened with some of the race-based testing that takes place in a variety of states south of us. So with that being said, when we couple reluctance with where they're doing the CARV, I agree with the person who asked the question, should there be more in our community? Yes. Will there be more? We hope so. And we want to continue to have town halls like this so we're brought to the table. Lydia Joy, do you want to weigh in on this? Because I know that you've got that deep background in human genetics as well, and you may want to respond.
I do. So to 2 points, I think we've covered the numbers, but to add to the first part of it is the race-based data collection. So we are now saying that we are so disproportionately impacted. When we started testing, at least for here, we were not testing to know the numbers that we were impacted. So maybe, there would have been more of even an encouragement of testing within our communities if we realized the disparity. But from my seat, when I'm looking at from a human genetics point of view, I think I have to say, race still is a social construct. So yes, we do need to do race-based data collection. Yes, we are seeing these disproportionate numbers, but it's also what we have to be looking at are social determinants of health. It's not that necessarily that only that there is a specific gene we're going to look at, like this is what makes Black people as a monolith more susceptible. It's these other factors that make us more susceptible and have disparities in a variety of different chronic and acute illnesses. And so as much as we're asking for this data collection and we're seeing a rise in our communities, we have to also really ask ourselves what those underlying factors are, and that we don't push now the needle the other way to say, well, Black people are this specific entity, and because of this is why we are susceptible and this is why we're dying. In terms of genetically, we are such a rich mix. We are the whole, literally the entire world has been birthed from us. So, you know, depending on where we're from and depending on the history of colonialism and how much we have had like different type of mixing and impacts, it's not necessarily that biology and genetics alone is what is making us more susceptible. It is racism. It is these other social determinants of health that are why we are seeing higher rates. So yes, we do need to have more of us included when the testing is happening. We do need to have more of us including in every step in what's happening now. But it's really all the other social determinants of health that we really need to be examining of why we have been hit so hard in our community. And it's not just alone a biological determinant. I think we need to keep that in mind so that we don't purport this idea of, you know, further racism in our community and stigmatization that says that because you are Black, we are the vectors of this disease. That's not what it is. It is the other factors that have put us in this position to be more susceptible and why we have to look out and care for ourselves within our community.
Well said. It's where we live and how close and what our access is to health ports, to community care, to facilities. It's the gentrification of life. So well said, and I thank you so much. Angela, I'm going to ask you for the next question.
Okay, question. Why is it that Johnson & Johnson only requires one shot while the others need two to be administered? And following on that is, are single dose vaccines more effective than double dose vaccines?
I'm half smiling because the community is asking some of the best questions that I've heard in the last few weeks. I'm going to go to our resident immunologist, Dr. Zayed, if you could please start off with answering the Johnson & Johnson question. Thank you.
No problem. So one dose versus two dose, it doesn't mean one is more effective than the other. It's actually just about how the vaccine is created. To be honest, we actually have certain vaccines in our current kind of regimen where some of them are 2 doses and some of them are 3 doses. It's about how it was studied that you needed a booster dose to get the effectiveness they wanted to achieve. So, you know, for all of them, they go through kind of phase 1, phase 2, phase 3 studies. And if they notice in the earlier ones, after they look at safety, they start looking at dosing to see which one gave them the highest kind of effectiveness. And they noticed that they required 2 doses to get to the effectiveness they wanted versus another form of a vaccine was able to do it in 1 dose. It doesn't mean one is better than the other. It's just the different ways things are made. So it's more of a kind of, you could think of it like a production thing, you know, versus thinking of 1 dose being better than 2 doses. So the number of doses does not actually change, it doesn't make one better than the other.
Thank you very much. I'm going to tag on with, is the Johnson & Johnson vaccine appropriate for people over the age of 65?
So at this time, I've not received any kind of indication from the National Advisory Committee on Immunization on restrictions of the dosing for that. It hasn't really, we haven't actually started receiving it and making kind of those decisions. They'll make that decision reviewing everything because, as I mentioned, you know, there is some data for AstraZeneca. They just didn't feel it was, you know, enough for them to say that in Canada. So we'll have to wait for theirs. They make those kind of final decisions because they want to basically position Canadians to be able to get the best response from the vaccine program. So we'll wait to hear what their final recommendations are.
Thank you, Dr. Abdirahman. Anybody else? Would anyone else like to weigh in on this question?
I just wanted to maybe just add that I think we're very fortunate to have at least different types of vaccines that we can immunize our population from. And, you know, you also have to remember that if you have a contraindication to one of the mRNA vaccines, which we have like the Pfizer and the Moderna, at least you have this other vaccine to fall back on, you know, the quote unquote AstraZeneca vaccine, which has been approved. So we also have to remember that, you know, in case you were to have a reaction, then at least we have something else to kind of fall back on as a backup that is, again, as effective in reducing, you know, hospitalization, reducing death. And so we should be very happy and fortunate to know that we have that available here in Ontario.
Thank you, Dr. Romain. Angela?
Okay, there are a few questions relating to this. I heard the vaccine changes my DNA. Is this true? There are about 3 other questions similar, but that is the most succinct part of it. And they want you to know, and is there MRC5 in these vaccines? Can you answer those 2 questions? Whether or not the vaccine changes your DNA and about the MRC5. I'm not sure what the MRC5 is, but that's a question.
I'll open that to the
panel. First half. I can take the first half. So it's not changing your DNA. I know the narrative out there is a very science fiction that it's like this little aliens coming in and changing. That is not what's happening. As you explained before, it's similar to how your body would respond if you were sick naturally. It's teaching it how to create a protein. And I think Dr. Zainab really explained it much better at the beginning so that when your body sees this again, we know how to have our immune system attack it. It's not that it is changing your DNA. Our DNA is very much better protected than that. If that was the case, every time you walked out in the sunlight, every time you walked everywhere, you would be reconfiguring. And this is not what happens. There are multiple layers of how our genetic coding is protected so that it cannot be altered so easily. This is not to say that mutations don't happen naturally. This is not to say that things do not alter, but not in this format. There's natural ways in which our body and our DNA works to produce all of the proteins and all of the things that we need daily. And this is just replicating and going with that natural system of production.
Thank you very much, Lydia Joy. Does anybody else want to, at this point, weigh in on this question?
Sure, I weigh in as well. Thank you, actually, Lydia Joy, that was great. Just like what Lydia Joy said, our DNA is well protected. You have a cell, and then within that cell, there's this nucleus, which is like, think of it like Fort Knox. And then within that, there's like almost like a panic room, and that's where your DNA lives. And if your body wants to make proteins, they make a photocopy of your DNA, they send it out, and then you make proteins based on that. But the photocopy can never go backwards, okay? And as soon as it's done making the protein, it is tagged for destruction. The reason it took us a long time to get mRNA vaccines was they were trying to find a way so that it could kind of stay alive, kind of stay around long enough to get the proteins made, because it gets targeted for destruction. Like as soon as it gave the instructions to the protein makers, basically it is like tackled like football, like everybody is jumping on them. They are cleared and they're not able to go backwards, right? So as humans, the way we're built, we don't have enzymes that can reverse engineer that into your DNA and put it into your DNA. So we do not have that. So that cannot happen in humans. And just to put it in perspective, people are so worried about mRNA affecting them. I want you to know that when you catch a common cold, the way it works is this virus comes into your body and it starts making its mRNA in your body so that it can make more versions of itself. So you are exposed when you get the common cold, and the common cold, by the way, is caused by about 200 different viruses. So these are happening, your little kids, when they're in daycare, everyone has seen mRNA from viruses so many more times before, but we've seen the intact one. We're only giving you a tiny, itty little bit of it, right? Versus you usually see the whole mRNA and you build a whole virus in your body. So this is not the first time your body has seen viral mRNA, nor will it be the last, because we will still be able to catch various types of infections in the future. I'm going to attempt to tackle the MRC5 as well. So MRC5, if I understand correctly, is referring to some of the fetal cells. And so essentially what happens is when we talk about some of the viral vector vaccines, so not Pfizer, Moderna, which are the mRNA ones. So that was the mRNA question. So the viral vector ones, the way they're made is by basically finding a cell culture that can replicate this viral vector to put into the vaccine. So there are different kinds of cell lines that we grow things on. So, I'm sure everyone knows the story of Henrietta Lack and how, her cells were taken without her consent and are continue to be used today because she had a certain type of tumor that was rapidly, replicating, and they use her cells because they rapidly replicate, so you can grow things in them. Similarly, they've also cultured cells from different cell lines, and one of them is from fetuses that were aborted, and it could have been natural abortions or such, but they cultured some cells from that. And then those cell lines, similar to Henrietta Lacks, continue to proliferate and are used in some studies. So with that, so that means like, but this was also about 40 or 50 years ago. This is a long time. So they're not aborting fetuses to get cells. I want to be clear about that. They are taking these cells that continue to replicate, because that's the thing about fetal cells is they do that, or tumor cells, they kind of keep rapidly replicating. So you can keep them, you keep culturing them. So for that, the Johnson & Johnson study did use those cells in the initial making of this. So they replicated it, but the cells don't go into the vaccine. They just replicated the viral vector, and then that is in the vaccine. So that's kind of where that comes into play. To be fair, you know, I know that some people have some moral concerns about this, but you know, from a religious aspect, I know certain religious leaders have spoken and still recommend the use, including the Pope, if that helps for some people in terms of that. So some, they have kind of talked about it in terms from a religious aspect, because some people have some moral concerns about that. But it's not, there's no active kind of recruitment for those cells. These are cells that were taken from fetuses that were aborted decades and decades ago, and they're just using the cell line. Similarly, we use the HeLa cells, which are from Henrietta Lacks. That's why they're called HeLa. And we use that for many. And that for many types of research that we do that has resulted in many treatments that we use today. So we have to acknowledge that as well. So that is there, and that's where that MRC5 comes from. I don't know if anyone else wants to comment on that.
For someone who didn't want to talk about the MRC5, you were brilliant in your review, as well as the support to the mRNA. Does anybody have any additional comments that they want to weigh in on in reference to this?
Can I say one more thing? I just noticed a comment that came in and said, aborted fetal cells are in all these COVID vaccines. They are not. One vaccine used them. The mRNA ones do not apply.
Yeah,
so,
and I said no 5 times when you had mentioned that. So
yes.
I'm glad someone asked it, but I'm glad that you clarified that as well. Angela, I'm going to ask you for the next question.
I told you all you were going to get factual information today. We are no holds bars, and it's a safe space. A follow-up on the mRNA of someone is saying a vaccine is defined as a product that stimulates a person's immune system to produce immunity to a specific disease, protecting the person from that disease. This mRNA for COVID-19 doesn't do that. This is what the person is saying. Is that true or false?
That is false. That is exactly what it's doing. So you are getting a little piece to tell you how to make this protein, and then your immune system makes antibodies, crunches that up so it can recognize that protein even from different angles. And then so that if you are infected with it, your immune system will recognize COVID-19 and will protect you. So that's actually exactly what it's doing. So these mRNA vaccines do meet the definition of being a vaccine. So they do stimulate your immune system to produce immunity against a specific disease for COVID-19, and it protects you from that particular disease. So whenever we give you those percentages, we're talking about protection from COVID-19 disease, and then sometimes we put it up into death by COVID-19, severe disease, or overall infection, but we're focused on COVID-19. Thank you.
Thank you.
Yeah, another question. As we're learning new strains of COVID-19 are surfacing, what are the results of the vaccine working against these, and how sure, given the timelines, are you that these current vaccines would be effective on these new strains?
Another immune-based question, but I will open it up to the panel floor.
You've muted, oh, okay.
Can you hear me?
Yes, now I can hear you.
Okay, great.
I can start, and then hopefully others will be able to comment as well. So it's not unusual for us to see strains happening, right? So the reason why a lot of these vaccines have focused on the spike protein is because it is a part of the virus that is key to it. That's actually how you recognize this virus, is because they have these spike proteins all around them, and it creates what's called the crown. It looks like they're wearing a crown, and this leads to their name of corona. Okay, so yes, in terms of variants, there will be there, and they're doing studies now to show how much protection each of the different ones have to the different strains now, because they're looking at that. So, but from what we can see so far, Moderna has published some of the data, and I think Pfizer is coming up with some. They are showing effectiveness against the strains. It varies. It's not always the same as the wild type, but that's not unusual to see that, right? That's similar to, you know, when we get the flu shots, we have different strains, and that's why we put different strains into the flu shot. And it's not all the strains, but you still get some effectiveness against other strains that are not the kind of four that are in the vaccine. So that's why a lot of them focused on this part of the virus, because it's so maintained in that type of a virus. That's why, versus just picking the whole thing. They're picking something that's conserved and is part of the other variants. But with time, they are now studying it formally to see how much protection against each of the different variants. And, you know, this might be like the flu shot in the end, where we get boosters each year and they kind of incorporate various strains, because that's what we do with the flu shot. We look at Australia, who has their winter and our summer, and we see what strains were very predominant. And then we modify the flu shot to make sure that it will kind of protect against the most popular strains that are causing severe disease.
Thank you for that. I'd like also the panel to respond pertaining to children and the vaccine. We have a lot of individuals asking rapid fire questions right now pertaining to youth and children. What are any comments that the doctors and or specialists have on children and the vaccine?
I just wanted to say, if I can add, you know, we have to remember as well that, you know, viruses, they mutate. That's what they do. That's what they do to stay alive. That's what they do, you know, to kind of, to remain stronger and stronger. And again, you know, I hope that by the end of the night, if people had maybe some questions or concerns about getting the vaccine, hopefully by, you know, towards the end, we might have been able to sway their, you know, or maybe debunk some of those myths, because I feel that maybe the longer we wait to get vaccinated, then the longer we give this virus to get the opportunity to mutate again. Right? And we can't really pick and choose whether it's going to mutate to be more virulent, therefore more transmissible and maybe deadlier, or not. We have no way of knowing until, you know, time goes by. So that's one thing I wanted to say. You know, if there's no host, then there's no way that the vaccine will stay in circulation. So again, you know, making sure that we vaccinate, test, self-isolate if we're not feeling well, washing our hands, socially distance, very, very important things to do. When it comes to children, you know, Pfizer has been approved for 16 and over, while Moderna 18 and over. But there are some situations, and Dr. Zainab may want to comment on that, where in specific groups in children between the age of 12 and 15, if they are considered high risk condition, and they would be in a situation where they're in, you know, congregate environment, then there may be consideration for vaccination for these children. And again, that's only with the Pfizer vaccine at this point. And obviously they are doing studies right now in children for vaccination as well.
Thank you, Dr. Romain. Dr. Zainab, Dr. Kenty at Lydia Joy, would you like to weigh in on the question pertaining to youth and children?
Sure, I can start. So as Dr. Romain said, that's correct. So for those who are kind of at very high risk, living in group homes, similar kind of Essentially, you can think of it as pediatric kind of long-term care homes who require special supports, et cetera. Those congregate settings have very high risks. So that is being given. And also, in one of the locations of the Pfizer study, they did actually include some 12 to 15-year-olds, and that's actually why it's actually being done. It was only a small portion, and now they're actually doing their bigger studies. So for children, children are not little adults, and that's why they are getting their own dedicated studies looking at these age groups. And even, looking at an older child versus a very young child is very different. Even if you just look now at the way we vaccinate for something like, let's say, diphtheria, tetanus, you get multiple initially when you're quite young, and then we're able to, as we get older, spread into every 10 years in terms of boosters. And that's because our immune system is changing over time. So each of these age groups are going to get their own studies because we don't want to just, extrapolate and assume. We want to be able to tell you about the safety, tell you about how well it works in children. Do they need an extra dose because of the way their immune system is? Are they more naive? So we are getting those studies right now. I know both Pfizer and Moderna are looking at kind of, I guess, the use age formally, and then they will go kind of keep going younger from there. And I believe AstraZeneca and Johnson & Johnson will be doing that also next. So those are being done. And so right now we're kind of doing this phased rollout, and hopefully what'll happen is we're going to cocoon them by keeping all the people around them, all their adults and kind of older siblings and family and teachers and everybody around them to be vaccinated. And then we'll then hopefully keep moving in and in and in on this kind of small population that's in the middle, which are the younger children. And if Lydia Jo, I feel like you're about to say something.
Oh, no, I was just going to add the same thing. I think it just goes back to when we're saying, what are the numbers that have been tested on? So same as we were saying, why was there only 10% of Black people? Like, it's the same thing. There's also sometimes a hesitancy to be able to test in children. They don't have the numbers that they need to say, unequivocally say that it's safe. But I think the other thing, and anyone else can jump in, is that fortunately, we're also seeing a lower mortality rate in children under 12. And so yes, the long-term wise, we're looking at that, but the risk and what we're looking at, the priority was in those who were seeing the highest mortality rate, which was not children under 12. And so the focus was on those who, that's what we were seeing a higher rate of.
Thank you.
If I could just add one point, because I saw in the chat, a lot of trust questions, some medical doctors are saying making contrary statements about the vaccines. How do we analyze what they say? How do we weigh what they say? And it's all about the evidence. It's all about the evidence. The evidence for vaccine efficacy in children has not yet been established. It will be soon, and then we can have a discussion about what does the evidence indicate. But without evidence, anyone is free to articulate an opinion. And just because someone has a title, that doesn't mean that opinion has validity or veracity unless it is backed up with evidence. And so what we say to people is, you are quite right not to trust until that trust has been earned. Many institutions have shown themselves to not be deserving of the trust from people of African descent because they haven't had our backs. And I'm not here to list them or list the situations which warrant concern. I'm just here to say it's about the evidence. And we have people now. We've actually always had people who can actually assess the evidence. We just haven't brought them together like this and say, what does the evidence indicate for people of African descent? And that's what we want to provide to the people of Peel, the people of African descent living in Peel, is what we, from our own vantage point of science, grounded in the African experience, can attest to based on evidence, not just opinion, evidence. And if anybody wants to come and have an opinion, that's fine. But show me the evidence.
Well said.
If I can add to that, actually, I think I saw those questions and I really wanted to respond to that too. I think we're not trying to have one voice. We're not trying to silence people from asking questions. That's healthy, especially in light of our history and what we know. But we also have to look at people have different risk management, people have different risks that they're willing to take. So even when we're looking at numbers of 90%, someone might be like, I don't even want a 0.1% risk, and say, you know, and so therefore what their advice would be, regardless of their station, whether they're a medical doctor, whether they're a researcher, they might be looking for a 0% risk, which is not possible. And sometimes, you know, their fear or their anxieties or their level of risk taking will also inform the advice that they give. It's something for us to, we weigh in it, but you have to weigh the source, the evidence, and what is that person's personal experience and what risk are they willing to take and what risk are you willing to take. So as we said, it's not here to say, here, what the end of this conversation, tell you what to do, but know what the right questions are to ask. So what is your level of risk? What are you risking in the decisions that you're making? And what is the evidence that you are using to validate and to support that decision that you're making?
Well said. And for those on the line sending in questions, if you have immune deficiencies, if you suffer from diabetes, hypertension, liver disease, cancer, this is the forum where you can ask the physicians, where you can ask the researchers, where you can ask those who look at the analytics, what will I be faring or what will I be facing? This is a safe place. This is an opportunity to educate and to inform, but it's also an opportunity to ask direct questions. We're not telling you not to drink your grandmother's tea, but what we are also saying is the best form of medicine first comes with a prescription of common sense. Use this opportunity to ask questions. Angela.
Yes, we have some of those personal questions right now. And I am going to say with half an hour, well, just over half an hour to go, we are not going to get through all of these. So we're going to have to find a way to capture these and really get them back to the community. So the Black Health Task Force is going to have to look at that to be able to get this information back to the community. Well, the three here that are really personal here in a person, she said, will there be a problem for me not getting this vaccine since I'm allergic to tetanus vaccines? I am in my 70s, and can I also request the vaccine I prefer? And a few people have asked that, do they have a choice of the vaccine? Answer that, and then there are other two personal ones that I wanted to bring as well.
That's definitely a Zainab question.
It definitely is, but I want to state this, having gone to a vaccine clinic, they're in the plates. They ask you to come up. It's not, can I have strawberry? Can I have chocolate? Can I have vanilla? It's truly take what's available and be lucky if you get one, if the vaccine is what you want. No one here is going to tell you what you should or shouldn't do. We're just going to tell you what's best and what's safest. So I'm going to turn to our resident immunologist, Dr. Zainab.
So in terms of that, in terms of being allergic to one vaccine versus the other, you know, it's not that having an allergy to one vaccine or an allergic reaction to one vaccine puts you at higher risk for reaction to vaccines in general. Essentially what we do is we look at that vaccine and we see, oh, are there any similar components between this vaccine and the current vaccines? And, you know, for those who reacted to tetanus, diphtheria vaccine or the TD vaccine, or even Adacel, the one good thing is actually both of those vaccines, which are the tetanus, diphtheria, kind of polio ones, they actually don't have similar components to any of these 4 new vaccines. So in terms of reactions, you know, we worry if people have reactions to some of the components of the vaccine, and these vaccines do not share the same components as the tetanus, diphtheria one. So that would not be a contraindication. Because sometimes at the vaccine clinic, they may not be able to go through all of this in detail. Sometimes they ask for you to have talked to your doctor first or talk to someone just to figure it out. But essentially we go through and we see if there's any similar components. And I can tell you for the tetanus, diphtheria one, because it does come up a lot. A lot of people have a lot of large local reactions, a lot of kind of responses to that vaccine because it's one that we see a lot, but they actually don't have similar components to either the mRNA vaccines or the viral vector vaccines. So any of the 4 that are currently available in Canada. So that would not be a contraindication to you getting this vaccines. And like Dr. Duncan said, honestly, there's not going to be a choice. Just like when you get your flu shot each year, there's usually about 4 different brands available and you just kind of get whatever is available at that time. It will be similar. Obviously, as we know, based on age, you may not get certain types based on your age, but aside from that, it'll just be whatever is available at that time.
And
Okay.
also, as part of the vaccination clinic, you know, there are physicians that are available on site. And again, having an allergy to, for instance, the tetanus vaccine is not a contraindication. However, we always recommend for people to stay, as opposed to the, you know, instead of the typical 15-minute window, we do recommend that people stay on the premise for maybe 30 minutes. And again, you know, the allergy per se may not be a contraindication, but it's really more the anaphylactic part, right? So if you start having kind of trouble with your breathing, tongue swelling, these are really kind of the concerns that we want to know about, making sure that obviously you are safe if, you know, something like that were to happen. But again, like, you know, in my experience working at the vaccination clinic at Osler, it's been kind of a very, very safe vaccine. You know, I think the oldest person that I vaccinated was probably 94 years old, and you know, they were like no issues whatsoever. And so, you know, that's kind of the one piece I wanted to add to this. Yeah.
The latter part of that I'm going to say for those who are on the line, someone I spoke to quite early on today, tongue swelling, the anaphylactic elements, the allergic reactions, contact your physician immediately. Get to a clinic, tell someone, don't wait 1 or 2 days and allow that tongue to swell up and sort of fill your mouth, or allow those bumps to cover your chest cavity, et cetera, et cetera. Speak to someone.
And
Actually,
also you bring up, oh, I'm sorry.
Sorry, I was going to say that was a question as well, of if they should wait, if they have a reaction, should they wait and see if it goes away? So that is a very good point that you made there, Dr. Dion.
Sorry, I was just want to add that obviously, again, as I said, there's always a physician on site at the vaccination clinic. And so if you feel unwell, you're not comfortable, if you're not sure and you just want to ask a question, we're always available to answer questions. And also, if you know that you have an allergy, you're not really sure, you know, use this time now that we're still in phase 1. You may not be part of the vaccination rollout as of yet, based on age or depending on your occupation. Use this time to talk to your family doctor or your nurse practitioner and say, what do you think of this? And we do recommend at the vaccination clinic that people that may have specific immune disease or that have certain allergies they're unsure about, to make sure they reach an allergist, they reach their specialist and have that discussion. At the end of the day, it's about risk benefits, right? We do know that the vaccine is very, very safe. But again, you have to be comfortable with that decision, of course. And so, going through to an allergist, do some allergy testing. We have kind of a tool as physicians that we can use that's called e-consult, where we can actually, fire questions, clinical questions to leaders in certain specialties, rheumatologists, immunologists, pediatrician. So ask these questions to your primary provider, and we can definitely do kind of what we call an e-consult. As I said, we get an answer usually within 48 to 72 hours, and then we can go back to you and say, okay, based on this information, this might be what's best for you at this time, right? So again, we have to use our resources in the community, use your family doctor, again, your nurse practitioner. We're here to help, right? We need to hear these questions. And again, I'm so happy that we have this forum for people to be able to ask these questions. But you have to remember, you do have allies in this, and we're all in this for the same goal, right? Like we all want to get out of this, but at the end of the day, we want to do it safely as well.
Well said,
Could I say something? I just wanted to take off what you said about grandma's tea. And, because we get a lot of questions, and I see some in the chat really about, these various things that you can do rooted in tradition. And it's not either or. Drink the tea. I mean, I have about 100 different teas that have been passed down in my family. And, if I was in Trinidad, I'd run in the back, find a bush, get that tea, no worries. inoculation is part of African tradition too.
Yep.
Inoculation is part of African tradition too. In fact, inoculation was introduced to North America by an enslaved African mistakenly known as Onesimus, who came probably from Ghana. His name probably was Quasi. Quasi was brought to Boston and given to a guy, this Cotton Mather, who got famous because in 1721, when there was a smallpox outbreak, this African told his so-called master he didn't have anything to worry about. And then Cotton said, why? He said, because back in Africa, when we have smallpox, and when I was a kid, they would go around the village, sticking everybody with that pus that they got from the person who was sick with smallpox, and I'm protected. So Cotton thought this guy is crazy. But then he went around asking other Africans if that was true. And they said, yes, that's what they do. And they were from other parts of Africa, West Africa. And he proposed it to the people of Boston, who would say, we can't have nothing to do with that coming from Africa, coming from those primitive pagan people. No way, this is devil's work. In the end, they did it because it saved lives. So, it's not either or. And it is part of the African tradition. African people have long been involved in medical progress. It's just that our contributions have been ignored, omitted, or distorted. And this kind of conversation that we have sometimes about science seems to suggest we're only on one side. No, we're on all sides, having contributed to the forward flow of human scientific progress in all of the various sectors.
Well said, Dr. Kenty. From a task force perspective, when we were prepping for this town hall, I was an advocate for those who would remember stories of their grandmother going and picking a bush and boiling a tea and being able to, remove fever, etc. Of course, there's definitely a mix of scientific and naturopath, of earth and lab. And this is something that if we pull together and have forums like this where we have these discussions, then we'll find out what the best route of discovery is for our people. So well said, Dr. Kenty. Angela, this has been an amazing forum. I'm going to lead to you for the last few questions. Thank you so much.
Okay, there's one here. Does the vaccine have an impact on fertility?
Now that is a question that I'm going to pose to everyone.
Let me say, I have 5 children and I got the vaccine because I saw there was another question. Have you got the vaccine? I got the vaccine, but I could still have more. Vaccine does not impact fertility. There's no evidence to indicate it has a fertility impact.
Thank you, Dr. Kenty. Does
anybody? Yeah, so there's no evidence that fertility is affected. In the initial Pfizer Moderna studies, some women became pregnant because there's also that question about pregnancy and whether it is safe, and breastfeeding, whether it is safe. So some women became pregnant during the trials, and we do not see, there was no evidence that, again, there was any concerns about the pregnancy. However, one has to remember that the study was not designed, or the clinical question was not specifically to look at this vaccine for pregnancy, right? Like they did not recruit women that were pregnant. And this is being done now, again, because we need that evidence. But so far, they haven't seen any evidence of any adverse effect on newborns, or and same for breastfeeding. There hasn't been any evidence that it's affected, again, the infant or affect the breast milk. However, again, there's this part of caution because these studies were not done to specifically look at that, right? But if a woman does become pregnant, while she gets her vaccines, there should not be any concerns. And one has to remember, again, that we do know that if you are pregnant and get the COVID vaccine, then your risk of having complications during your prenatal course or at delivery is higher, right? So that's one thing. Again, it's a risk-benefit ratio that has to be looked at.
Okay, I have one here. I am a 73-year-old male, and I have no vaccine hesitancy. However, I have a concern regarding a shellfish allergy, and I need to know what research has been done in that particular area. If anyone on the panel knows about this.
Again, opening it up to everyone.
Well, I'll comment. So I see obviously a lot of patients with shellfish allergy. And as I mentioned, for people with food allergy and vaccines, the concern will be if there are those particular foods in the vaccine. None of the available COVID-19 vaccines have any foods in them. In addition, in the studies, people with food allergy were not excluded. I know people were concerned initially. There was some discussion that maybe there are people who did have allergies were not in those studies, but they were. It was only if you were known to be allergic to a component of the vaccine were you excluded from it, but there were no foods in the vaccine. So lots of people with food allergy actually were in the studies as well. So if you have a shellfish allergy, there's no concerns for you to have this. When we get concerned about food, for example, someone with an egg allergy, we get concerned if you're getting the yellow fever vaccine because there's egg protein in that vaccine. And it's not so much that you could never have it. It's that you can't have it in a regular fashion, not just at a regular travel clinic. Often you'll get involved into a vaccine allergy clinic where maybe we're going to give it to you in a different type of way to make sure that you can tolerate it. So that's when we get concerned about foods and vaccines. But none of these contain food. So even if you have an anaphylactic reaction to shellfish, you can still have this vaccine. So as an allergist, I'm able to recommend this for my patients who have known reactions to foods.
Okay.
Dr.
Dr. Kenty, you want to speak?
Yeah, I saw the last chat comment, and my blood pressure went up a little bit, but I have it under control now, so I need to respond. The guy said a panel with everybody on the same side is not a panel, or it could have been a lady. On the issue of Black Lives Matter, there's only one side, Black Lives Matter. It's not a question of Black Lives Matter or All Lives Matter. We only say Black Lives Matter because we see the evidence that the Black lives don't have the same value and aren't treated with the same level of respect as lives of other people. And because of that, we demand the situation be changed. We don't want to be superior to other people. We want our lives to have the same value as everybody else. And so we are dealing with a question about Black lives. This is about Black lives. It's about your family's lives, the lives of the community. And we want to minimize the loss. So there's no two arguments about that. If you have if you're opposed to that, you have to find another forum, create another forum, because we are all on one side. Black lives matter. That's the point. My blood pressure going on now.
I'm glad that it's.
Thank you, Dr. Kenty. Others
I
want
wanted to add to that because I saw the comment also, and I think I think it's fair to say that. I think sometimes because we speak, maybe we're speaking from a research lens or a scientific lens and using terms that seem neutral, it seems like it's advocating for one side or another. So we're saying things like there is no evidence. That is not that we're saying. We're saying exactly that. We don't know. There is no evidence. That is what the technical answer is. So, if it comes across, it's not pushing one thing or other. We are here to state what a fact is. There's no evidence. How you'd like to interpret that and how you'd like to add that to your arsenal of how you're making decisions is what we're presenting for you. So if I'm saying I do not know, that's not an opinion on one side or the other. And so I hope it doesn't come across that way. In transparency, I wish I knew everybody on this panel before, but we did not discuss. I don't know what side everybody's on. I don't know what our political views are. I don't know any of those things. We've come together from our areas of expertise, and you're asking us questions, and we're answering them the best that we can from honesty from those places, so that you're educated and informed to make a decision within those realms, so that we can share a body of knowledge for all of our benefit. And I hope that that's what it comes across as in the end.
Well said, Lydia Joy. I'm just going to add to that and say, from a scientific lens or from an informatic lens, you have a panel of people that fall within genetics, pediatrics, immunology, and research, and an area of allergy where we're giving you our personal opinions to the best of our ability for our community. There is no other forum that will be like this. I see a lot of questions coming across. Have we been vaccinated? Do we think we should be vaccinated? And we didn't want to, as specialists, communicate with each other previous to this forum, because we wanted to make sure that our views and the way in which we communicated back to you was real and holistic. To answer those personal questions one way or another would be an answer that I wouldn't have for each and every one of the individuals on this forum. So we're giving you the best answers that we can from a scientific, holistic lens that focuses on our community. Okay? Angela, I'll lead back to you.
Well, I think this one question would take us probably down to the end of the session. Someone is saying distrust in the healthcare system is not our problem alone to fix. Do you know of any work being undertaken by government officials, the heads of hospitals, or the Ministry of Health to repair the harm done to our community because of anti-Black racism that has historically played out as poor healthcare treatment? This failure to address this piece contributes to ongoing distrust, which then plays into people being skeptical about the vaccine.
I think it's a great question.
Sure, I can start, and I think everybody probably has something to weigh in.
Yeah.
You're absolutely right. It's not our job to change what has been done wrong. Our job is to take care of ourselves first, which is why we're here, is to inform and educate ourselves and strengthen ourselves. But our job is to hold those in power accountable. And so that is what we're doing. So by asking questions, by all of the things that we have here. So when we sit in places, we vote, we sit in town halls that are outside of here, and we say, these are the questions we have. These are the injustices that have happened before. What is happening? How are we having a voice? How are the things that we are concerned about being represented in the laws that are being made? How are we also shaping policy? So I know, we can definitely share other resources of who have been doing that work. There's various community groups who sit in these places, including where I sit with Black Health Alliance, and I know a few of the rest of us sit in other places where exactly what you're saying, to hold those accountable, to say, this isn't invalid, why we have questions, why there's a two-tiered system, why we don't feel part of the social health care system that exists, has not been looking out for us. And we are sitting there and questioning and saying, you have to be responsible up to why we have these questions, and why in the middle of crisis, we have to take a pause and say, well, this information is being given out by our government, but we don't feel like it is our government or that we have been a part of that system up until now. So definitely, I don't think it is our job to correct all that has been wrong, but there are things that we can do to, going forward, hold others accountable. And there's different ways that we can sit in our different seats of power and have our voices heard in ensuring that going forward, that is what happens.
Well said, Lydia Joy. I want to add to that and say Public Health Association of Ontario, the Ontario Nurses Association, ONA, Ministry of Health, they are now doing forums. Long-term care was ravaged by COVID in the earlier parts of this year. It's now, it's getting a little bit better, but the majority of people that sit on the front line, those clinicians, those registered nurses, those RPNs, and those PSWs fall within our community. So there are forums. There are the Black Doctor Associations coming together to say, these individuals need to be paid for their sick days, government. Subsequently, at the provincial, municipal, and federal level, these conversations are being had, because the reality is, if we get sick and we are on the front line, then who's going to do the work? So they are bringing us to the table, and we are seeing some of those slight changes, but there are new avenues of where we can either talk about this, have the discussion, and seek change. It's not going to be immediate, as Lydia Joy specified. A lot of it is siloed, a lot of it is watered down, but it is real, and voices are being heard. Dr. Kenty?
Yeah, I just want to add to that point. Again, I agree completely with what the individual said. The reason why some of these myths and misinformation is taking hold is because of the what people are experiencing in the system that gives them cause to pause, right? It's a deadly combination. They're not getting sick from COVID because you're Black. Or it's because of the systemic racism which acts through the social determinants as well as acts independently to create all these stresses which lead to the underlying conditions which make you so vulnerable. that high rate of diabetes didn't come from Africa. In Africa, it's 3% of the prevalence for diabetes is 3%. Over here for Black people, it's 8%, 4% for white people. In America, 12% for Black people. It's a systemic racism which is causing so much havoc and causing so much health harms to people of African descent, not the African ancestry. And so I agree with you completely. It's about eliminating anti-Black racism. And we have to make sure that coming out of this pandemic and preparing for the next pandemic, that we are in a better place, that we are not as vulnerable as we were going into COVID-19.
And again, to add to what Dr. Kenty beautifully said, when it comes to COVID disease, there's not kind of a genetic susceptibility for, minority, Blacks, Hispanics. No, it's not that. What it is, and it's been shown again in studies, that it is definitely the social determinant of health that affect someone's ability to actually die of COVID or have severe COVID disease. And so we have to address that. This is what we have to kind of work on as a community, not just the Black community, but as a community as a whole, to make sure that that people will have kind of paid sick leave, that people have access to healthcare, that they shouldn't fear seeing their physician or nurse practitioner, that they're able to actually see them, that they're allowed time off work to be able to book an appointment, that they have the financial needs to have, a healthy diet, to be able to exercise. And again, it's not just for COVID, but unfortunately, this pandemic has showed us that there's such a disparity between who gets the disease, who doesn't, who's able to be able, for instance, to work from home, able to self-isolate. These are all factors that as a community, we all need to look into and make sure that our politicians are aware. And I'm not saying that people need to be advocates and, start, going to their MP's office. If you want to do that, do it, absolutely. But there's a lot of ways to be advocates. You can be an advocate for your own by, talking to your friends, talking to your family, again, providing evidence-based solutions in order to try to reduce kind of these determinants of health that have such a big impact in our community.
Absolutely. Angela, do you have a final question for us, or will we be wrapping up this evening?
I think Dr. Zainab wanted to say something to that, and then we will wrap up. Yes.
Yeah, I was going to add to kind of what everyone has said. We're focused today on the vaccine, and we've really been trying to give you information so you can make the right decision for yourself. So today we focused on the vaccine, and you might think that's all we're focused on, but that's not it. There's still that motion that's moving forward with Black Lives Matter to address all the systemic racism that has led to all the problems kind of going against our community, and why we are having more poor health outcomes, why we are targeted, in terms of justice systems. That work is still being done. And I can tell you from the health perspective, a lot of associations are trying to kind of get in there right now. There's been a lot that has happened and has really kind of cracked it wide open, that the inequalities simply based on race, you really can't ignore it now. And now we have race-based data. So I can tell you the Black Physicians Association of Ontario and so many other committees, and we've heard about Black Health Alliance, we've heard about other ones. We're not only focused on the vaccine. Today we wanted to talk about the vaccine and make sure you had a safe space to talk about it, but there's other ongoing work because we realize why the Black population has been so heavily affected. And those are other things that need to be addressed. There's a long-standing history of systemic racism that has led to us being disadvantaged in our community. And there is even a bigger push forward at this time, armed with more data, and that advocacy is being done. We're not only, because the vaccine is one thing, there's still so many other structures we have to dismantle. So that work is ongoing. we've just
Well
focused
said.
on the vaccine today in terms of this forum, but I want you to know that that work is being done. And there's a lot of advocacy being done at all levels of government about Black lives in terms of health and in terms of the social structures, the social determinants of health, and that is not being lost.
It is rare that you will be able to amass a panel where you see all of these Black faces on at the same time. Sometimes we get split up. Sometimes we do TV panel stuff and radio stuff, but they're almost fearful to have us all on at one time, because this is powerful and this is boundless. So for all of those who've tuned in, thank you. Angela, I'll lead back to you.
Okay, thank you very much. And I want to say that's the reason we started the Black Health Task Force of Peel, to work along with the Black Scientists Task Force in Toronto and the others, that we can together push this forward and tackle all of those elements that you just spoke about. And Edisiri, I'm going to call on you to give the closing remarks and also to put up the poll to hear how people feel now after hearing this session today. So Edisiri.
So much. Wow, such incredible insights from our panelists. A seasoned lineup of panelists, of moderators, Dr. Lowe, our moderator, thank you so much for really bringing this dialogue to the community. And thank you all for participating as well, asking such honest, thoughtful questions, and ensuring that we have the answers that we need to move forward as a community. Over to you, Nada, if you can pull up the poll. So we just want to ask you a couple of questions. We hope that you've learned a couple of things from this town hall. And so if you can pick, choose confident or not confident after listening to the panelists, how confident are you about taking the COVID-19 vaccine now? I will give that a couple of seconds for people to pick and choose.
Did we have the results from the first one? Are we able to say what those were?
Yes, so the results for those who were able to participate in the first poll was just mainly to gauge where people's confidence level was in terms of the vaccine. And we had that at 51% of people who felt confident and 49% of people who couldn't feel confident. So almost a 50-50.
Yeah. So it would be interesting to see what the poll is now after they've heard the panelists, and hopefully, we hope they feel more comfortable. We're not telling them how to do, but how do they feel? And we're not telling them they must do or don't, because we just want to provide the information that can help them to make informed decisions to keep themselves and their families safe, and to keep asking questions. And as I said, Edisiri, we need to find a way of taking all of these questions that came in that we weren't able to answer.
100%.
Over 100 and almost 200 questions we got today, and being able to get the answers for them to send them back to the community. So we are going to work on that, and we are going to try to find a forum to send this out. And this is not going to be the last forum we have. No. We are going to look to do ones, and probably not on the vaccine again, but on some other health issues that we can bring to the community, because that's what we are here to do, to shed light on the what is happening, as well as to give a forum for our community to ask the questions and get truthful answers. So do we have an answer to the poll?
Yes, please share the results. Yes, so we have, this is significantly different. We have 74% of people confident and 26% of people not confident. So that's a significant increase from the 51 we had earlier, from 51 confident to 74. So thank you, panelists and moderator, and for all our speakers for really providing this important information we need to have as a community, really culturally relevant. I think it was incredible to see the range of questions, from personal questions to cultural specific questions, even to systemic issues and anti-Black racism. And so thank you on behalf of Black Health Task Force of Peel. We're hoping to have a lot more dialogue as a community. Our goal as the task force is beyond COVID-19, but to advocate for a stronger, healthier, and equitable healthcare system for us all. Join us on our social media platforms, and that's Black Health TF You can follow us on Twitter and on Instagram and on Facebook. The recording will be shared on our social media platforms, and it will also be sent for those who were able to register on Eventbrite. You will get that on Eventbrite, but otherwise our social media channels will have the recording and the YouTube link. So please, let's ensure that we continue this dialogue in our communities to ensure that we're stronger and healthier community as a whole. Thank you so much, and have a great night.
Thank you, Edisiri. Thank you, panelists, and thank you to all of those who participated as in the audience and for your questions. Thank you. Have a good night. Keep safe.
Thank
God
you.
bless.
Bye.